So I'll be speaking in English, but my slides will be in Spanish because it's a lecture, not a comedy show, because my Spanish is more funny than it's accurate. Do ask me questions afterwards, maybe towards the very end, after all the talks are finished, we can have questions, etc. So what I did was I combined the two, I'm going to do one talk, and it will cover broadly what is the update, what is the state of the art in maternal immunization. Okay. Better? Yeah. And this is the, that's interesting. So, maternal, yes. Yeah, that's right. Okay. So, infant immunization schedule has been very useful for public health, for medicine, for saving lives. Throughout the world, vaccines are either given, as you know, in childhood at most vaccines are given at the 6, 10, and 14 weeks, or 2, 4, 6 months, like the US, like in Guatemala. And that's the primary series. Some vaccines are given in some parts of the world at birth. A lot of them are now given later, but the primary series starts at this age. However, there's still a gap, even in the first 28 days of life, before we start vaccinating people, and vaccines do not start taking effect until after 2 or 3 doses. There's this immunity gap, and a lot of children are dying. And even in the first 28 days, 3 million children die. Not all, but a lot of these conditions are from infections. And if it's from infection, we can potentially prevent that infection through vaccination. And how do we do that? Because infant immune system is immature, and not all of these vaccines cannot be given, most of the vaccines cannot be given before a certain time, and because of interference from maternal antibodies. So therefore, we focus on, in certain cases, on maternal immunization during pregnancy, before birth. However, it's not just for the baby that we deploy the maternal immunization strategy. The mother herself benefits from a lot of vaccines. For example, certain infections are either more common and more severe during pregnancy, as Dr. Mario Malgar, I don't know where he is now, but as he described a little while ago. So this is an updated version of, so in the New England Journal previously there was a similar graph that Mario showed for infection. I updated it for vaccination. And so the basic thing is that you have sex hormones that go up. They go up generally by trimester or even by week of gestation. So I believe that when you are looking at immunology in pregnancy, and especially vaccine effects in response to infection, trimester is too crude a classification. So you should focus on things change week by week. And so therefore, I try to think of it, these things by weeks of gestation. If you see that the sex hormones are going up, but not in a perfect linear fashion. So they go up, plateau, and then go up, etc. That has implications because on the immune system, so there are certain things like monocytes, phagocytes, dendritic cells, etc. They go up. But the cells of the immune, the adaptable immune system and some of the other cells, they actually go down as the pregnancy progresses. And therefore, there is increased severity of certain infections, like influenza, hepatitis C, and herpes simplex virus as pregnancy progresses. But there is decreased severity for things like malaria. For example, first trimester or early pregnancy malaria is more severe. And then vaccine immunogenicity, there's mixed evidence around influenza, but there is generally lower vaccine immunogenicity in late trimester, for example, against Hep B, pertussis, and yellow fever. Before around second trimester, there's very little transfer of antibody from the mother to the baby. but it goes up, and it really picks up around 32 weeks. But it starts going up around like the beginning of the third trimester as well. So why do we think about that antibody transfer and the efficiency of transfer? Is because if you're trying to protect the baby, you want to time it in a way that the peak of your immune response is overlapping with the efficiency of transfer. So we need to consider that a little bit. So I'll talk a little bit about influenza. So influenza infections is severe as pregnancy progresses, as I alluded to earlier. So this was a really nice study from the US. These are severe outcomes or odds ratios of severe outcomes after influenza in a population. The reference is the postpartum period, and then there's non-pregnant, but then, as you see, compared to the postpartum period, with the increase in pregnancy in the gestation, with the increase in gestational age, there is an increase in severe outcomes after influenza. So there is a so-called, or for lack of a better word, there's a dose-response relationship in terms of bad things happening after influenza in pregnancy and the week of gestation. On the other hand, it's not only severe for pregnant women, the influenza infection disproportionately affects young infants, particularly those who are younger than 6 months of age. And if you remember, there is no vaccine available for infants no influenza vaccine available for infants younger than 6 months of age. So keeping this in mind, I was involved with this trial, the first randomized controlled trial of maternal influenza vaccination, and to look at the infant responses, and we found that there was 63% reduction in babies' lab-confirmed influenza. It was not PCR at that time, it was rapid test, but there was 63% reduction in influenza in the babies if you vaccinated the mother. The first question was, is this something happening due to breastfeeding effects? We know breastfeeding protects against infant response, against respiratory illness in the babies. But we looked at the distribution of exclusive breastfeeding, for example, in Bangladesh or in Dhaka, where this study was conducted. And there was overall very similar, but if anything, in the influenza vaccine group, the women were stopping breastfeeding, exclusive breastfeeding, a little bit early. So just keep in mind that this, it was pretty certain that it was actually the vaccine that was working. So based on this evidence and other evidence, WHO in 2012 said that if countries are introducing influenza vaccine, thinking of introducing influenza vaccine, they should prioritize pregnant women. And this was very useful in deploying this vaccine in a lot of PAHO countries. So, in Latin America, most countries have a recommendation of maternal influenza immunization. Based on our initial study, Gates Foundation, Bill and Melinda Gates Foundation, Bill Gates, who makes the software that runs on most of our computers, almost always works. Sometimes the software doesn't work, but the vaccines do work all the time, or most of the time. But in terms of after our initial study, there was a need for replicating it in a variety of populations. So influenza changes from location to location, and we wanted to see that there was a uniform effect or it's a generalizable effect. So based on that, the Bill and Melinda Gates Foundation funded 3 studies, and then I work as a consultant with them to combine data from these 3 trials. So what did we find? We found that it worked in protecting the baby against lab-confirmed. So for these 3 trials, it's PCR-confirmed influenza. The vaccine works in infants, but the efficacy ranges from 30% to 60%. So in a group that is particularly vulnerable, the vaccine is working. It's not perfect, but it is working if you vaccinate the mom, and it is pretty generalizable result. In the mothers overall as well, there is efficacy in protecting disease in the mother. In Nepal, it was not significant, statistically significant, but in the other trials, you did see an effect. So there is an effect in protecting mothers. So that was the outcome from these trials. But also, we were looking at some of the other outcomes, for example, birth weight, etc. But if you look at the two Asian trials, they were conducted in population that had a slightly lower birth weight on average than the African study site in these trials. So what we showed was, what these trials showed, that in Nepal, which was one of the Asian sites, there was an impact on low birth weight. In the two African sites, where the baseline birth weight was higher, there was no effect. And similarly, in Bangladesh, there was previously shown that mean birth weight was higher in the vaccinated arm, in the vaccinated group compared to the unvaccinated group. So there was some evidence. So could it be that we had a situation where the sites where there are more prevalence of low birth weight, or the average birth rate is lower, the vaccine was actually working to protect against low birth weight, but where it was higher, it was not. But it should also be noted that in Bangladesh, in Nepal, it was a pre-specified endpoint. So they had statistical power to actually detect a difference. And when they had the statistical power to detect the difference, they detected a difference in terms of birth weight. So, and then there's this other effect we found, that this is from Nepal, but we had similar data from South Africa as well, that there was a reduction in all-cause pneumonia. So approximately 31% efficacy in the infant if you against all-cause pneumonia, severe clinical pneumonia, if you vaccinated them against influenza. So that's pretty significant, because pneumonia is one of the biggest killers, and in young infants it's particularly severe. And a lot of, I'm not showing those slides, but there's a lot of evidence that virological infections predispose to a lot of severe bacteriological infection as well. So this is all-cause pneumonia that is being reduced if you vaccinate the mother. So the bottom line is maternal influenza vaccination is pretty useful in reducing lab-confirmed influenza in the babies. It is very useful in reducing lab-confirmed influenza in mothers. It is useful perhaps in certain populations reducing the prevalence of low birth weight, and more generally it can reduce all-cause pneumonia. So this is a summary. I will skip to pertussis, and in pertussis or whooping cough, there is there is a lot of burden of pertussis. 95% of WHO estimates 16 million cases per year. 95% are in low-income countries. A lot of them are in middle-income countries, in underprivileged populations of middle-income countries as well. So it is the burden is there. However, the babies get the more severe disease because of several reasons, and older people also get more severe disease. And there was a vaccine available, which is a combination vaccine, the Tdap vaccine, tetanus, diphtheria, acellular pertussis vaccine. And that was recommended in the US and in many countries. But it was recommended before they could do phase 3 trials, because based on phase 1 or 2 trials, because it's more rare than influenza, so they would have required a lot of time to do those trials. But at the same time, there was an outbreak in the US and the UK, and so they decided, based on the public health need, they recommended the vaccine based on phase 1-2 trials. But that meant that we had to look at the safety and outcomes associated with some important outcomes that could be of concern. So what we did was we looked at the safety of maternal pertussis vaccine. So we looked at the outcomes of several outcomes, but there was higher rates of chorioamnionitis in those pregnancies or in those mothers where that received pertussis vaccine, compared to those who did not receive pertussis vaccine or Tdap vaccine in the US. But what does that mean? Why do we worry about chorioamnionitis? The biggest worry is preterm birth. And we looked at it in this study on preterm birth as well. If anything, there were lower rates of preterm birth in the vaccinated arm compared to the non-vaccinated arm. So that was very reassuring. But when we investigated what was happening in, why were we seeing higher rates of chorioamnionitis in the pertussis arm? Well, it turned out only 40–50% had actual diagnostic evidence, the supporting diagnostic evidence for chorioamnionitis diagnosis in pregnancy. Well, in the US, there is a lot of litigation, a lot of lawsuits that lawyers file against OBGYNs, and often a lot of the third trimester fever is labeled chorioamnionitis without a lot of diagnostic evidence. So that's what was probably happening. But we continue to follow that, and therefore the Advisory Committee on Immunization Practices, or WHO's Global Advisory Committee for Vaccine Safety. I'm now a member of that WHO's Advisory Committee on Practices on Safety, although the safety evaluation of these vaccines happened before I joined. But in any case, even after looking at these data from us, it was decided that it didn't warrant any change in recommendation. We also looked at it in the US. Pertussis vaccine is recommended in all pregnancies. So specifically with the tetanus component, because since it's not just pertussis vaccine, monovalent pertussis vaccine, it has a tetanus component as well. You're sometimes concerned about giving tetanus shots too closely if something is there, especially for reactogenicity. So we wanted to see if, compared to the shots given, previous pregnancy happening and them receiving a tetanus-containing vaccine more than 5 years prior to the current dose, if there was a gap, was there an association with a gap of less than 2 years, 2 to 5 years, with 5 years greater than 5 years as reference? Was there an association with local reaction of the gap between the two Tdap dose, tetanus-containing vaccine doses, or small for gestational age, or preterm delivery? None of that was significant. So those data were very reassuring that the birth, the pregnancy outcomes, etc., were very supportive of safety of pertussis vaccine. Now, for Group B strep disease and vaccine. So Group B strep is, there's the late onset and early onset Group B strep disease. The early onset is often presents as sepsis without a focus in the babies, or pneumonia and meningitis. The late onset, that is after the 7 days, 7 to 90 days, early onset Group B strep disease in infants is before 7 days. When that happens, it's meningitis is most frequent, and they have long-term sequelae. So it's pretty severe and has pretty substantial consequences. In the US, we have universal screening, and they give intrapartum antibiotic prophylaxis based on that screening results, so people get antibiotics. And even the coverage of that is pretty phenomenal in the US, and your other OB colleagues in the US will tell you that it works really well. But with that, there was a reduction in early onset disease, but no reduction in late onset disease, even in the US. So we are protecting early onset, and then it leveled off after a while. So a vaccine will potentially have an impact both in early and late, especially in late onset. But the infections with Strep B invasive disease, so a proportion of them, this is a national surveillance study, on 10 sites, several of them had invasive disease. If the mother has invasive Group B strep disease, approximately 2/3 of them had a spontaneous abortion or stillbirth, and then you had either 5% clinical infection, and actually there were 4% induced abortions as well. So invasive GBS disease in the mother is pretty substantial for the fetus, and so that's the other aspect. And also in the post-pneumococcal era, at least in the US and wherever it has been looked at, for young infants, pneumococcal disease and Hib disease has been replaced by Group B strep disease. Although the overall rates of invasive meningitis, for example, and bacteremia, etc., have gone down overall, but there has been a replacement of the main cause of some of these outcomes in young infants. So this vaccine is potentially important to address that. So we have a lot of evidence that if there is, first of all, if you have colonization with group B strep, which is not, that happens quite often, if there is an invasive disease, there are bad outcomes of preterm birth. As you know, preterm birth is a pretty consequential entity when we're dealing with maternal and infant health. But we don't, what there is initial evidence of, that just colonization without invasive disease through systemic inflammation, does that cause preterm birth as well? For that, the evidence is emerging. It's not certain. So interestingly, overall, if you have combined cross-sectional and pools, you combine cross-sectional and case control studies, there is an effect on preterm birth of just colonization even without invasive infection. If you do cross-sectional case control separately, that remains significant. Sorry, this is for me to take allergy medicine. So I come from Atlanta. We live in it has a ton of trees. We virtually live in a jungle. It's those of us who are there, we get allergies. So even if when you are traveling, I continue to take it so that I suffer less when I go back home. And so, and then you have cohort studies where there wasn't, which are better quality studies. More studies have shown that there is an impact on preterm birth of just colonization, but cohort studies haven't shown it. So it's a mixed picture. So those of you young researchers, et cetera, who want to evaluate this research question, it is a good research question if you do high quality studies. So not just young researchers have to do this research. People who are young at heart can also do this kind of research, but it's an important sort of emerging question. So the progress is, there was a product that was 3-valent by Novartis. They had a few trials, and these trials were reasonably successful, but the company was taken over by GSK. And since then, the official line is that they want to add 2 more antigens so that it has a global coverage. But frankly, there hasn't been any progress in an actual clinical development. So hopefully there will be revival of this kind of a program by that company or any other company, because there is a public health need for this vaccine. So then you have respiratory syncytial virus. That's another target for maternal immunization. If you look at the risk factors of hospitalization and RSV related outcomes, you look at age younger than 5 months, which is the target for maternal immunization related protection, and preterm birth are independent factors for risk factors. In certain countries, you give passive immunization or antibody at birth for premature infants because they're susceptible to poor outcomes after RSV or respiratory syncytial virus disease. And it's a major cause of mortality, of death. 2.3% of all deaths in the neonatal period happen through RSV or respiratory syncytial virus. Even through the rest of the infancy, which is 28 to 364 days, this ratio, it actually goes up. So a lot of death is happening between actually 90 days and 6 months of life because in the early 90 days, whatever antibodies are there from mom quickly wane, which are naturally acquired. The quantity is not that much, and then you have a lot of mortality. And the mortality and the case fatality ratio is a differential by age, but also highly different, is much higher in low and sometimes even in middle income countries, especially in underprivileged populations of middle income countries. So it is a pretty substantial disease. There are a lot of products that are in development. There is and this is the passive immunization, just the antibody. This is the one, this vaccine from a nanoparticle-based vaccine from Novavax just finished. They just announced the results of this trial. I will show you the results. That's the more advanced one, but there are other projects that are in development. So there's a lot of exciting discovery happening and development happening for RSV vaccine around the world. And the good thing is, in order to make sure that these vaccines are as soon as they're licensed, they're available globally in middle-income countries and low-income countries as well, Bill and Melinda Gates Foundation has invested approximately $80 million in this program, so that with the condition that it will be available in most of the world almost simultaneously. So that's very reassuring. But the results that came out were mixed. So the pyramid is that there are more infections, there just asymptomatic or symptomatic infection, only a proportion of that is lower respiratory tract infection, and a proportion of that is LRTI with hypoxemia or tachypnea. And then this was the primary endpoint of this trial, hospitalization and severe hypoxia. So they observed vaccine efficacy that they showed was inverse of the more severe the outcome, the higher the vaccine efficacy. But there is a nuance to this. The primary and secondary endpoint was, which is based on the side data, etc. This was not significant overall. So this was, but with the hospitalization, it was significant, but the more severe outcomes were significant. So the primary outcome, unfortunately, was not significant, but a lot of secondary outcomes, which were more severe, were significant in this trial. So it is one of those trials where the FDA and other regulatory agencies, Food and Drug Administration that licenses vaccine in the US, and other regulatory agencies will have to pay attention to data a little bit more. It's not automatic. I think the vaccine is doing something beneficial, especially against severe outcomes, but they did not designate that as the primary outcome. So there will have to be a judgment call by the committees, etc. It's not an automatic approval. And so overall, in terms of the RSV vaccine that came out, vaccines appear to be safe in mothers and infants. First RSV vaccine to demonstrate efficacy against RSV hospitalization in a phase 3 trial. Prevention of RSV LRTI hospitalization and RSV LRTI with severe hypoxemia are key findings. There is a reduction in all-cause hospitalization, etc., and they will present these data to the regulatory folks. So a little bit about the ethics of maternal immunization as I end this. So there is a question, is maternal immunization ethical if you're vaccinating the mothers for the benefit of the baby? And there have been discussion of that, and wherever we have measured this, turns out that moms find it in their interest to protect the baby. So if you ask them, their huge motivation is to protect the baby, and we have data to show that. So therefore, we proposed an ethical paradigm accounting for that, that basically says that legitimizes and legitimately recognizes a mother's interest to protect the baby. So that's why it is ethical to vaccinate the baby, because moms want it, essentially. If you ask mothers, they want to protect the baby. It's an informed decision to protect the baby. So what are some of the characteristics? That it recognizes maternal agency, that they have the power and the ability to make decisions to protect the baby. But the other thing is that when you are making decisions about maternal immunization, women should be part of decision-making bodies. If they are in the, things like in the TAG and CONAPI, etc., it shouldn't be only men making decisions, because that's where you empower decision-making for those who are more directly, or at least representative of those who are directly impacted and benefited by this vaccine. But on the other hand, because there's a fetus involved, in certain countries, infant vaccines are recognized to be okay for mandatory vaccination. For maternal vaccines, the criteria, the threshold is higher. You should be very careful about mandating it. So that's the other difference. So this is my team, some members of my team that worked with me in Atlanta, but I have other members there as well. But here I want to recognize my colleagues who have worked with me for several years. This is Herbert, John McCracken, and then many others. Can I request my colleagues from Guatemala to stand up and and be recognized for a minute, please, because they have worked really hard on several studies, including a recent trial that we completed to generate high-quality evidence that would inform our studies. So that's Carmen, and then that's Maria. And so not only that these findings that we are about to come out with of a maternal pertussis trial that I didn't present because we just completed the study will inform evidence here, but I'm presenting it at PAHO TAG in Colombia, will inform the region and will undoubtedly inform other evidence as well. The good thing I can say is, without going into a lot of details of the results, there was a very good safety record of those vaccines in those trials, and detailed results are forthcoming. So thank you, and that's it for me.